All right, so I don't have the most engaging title because it's still a work in progress, but it tells you exactly what I'm looking at. So it's Autism and Service Claim Approvals in Arizona. Excuse me. Oh, wait. Okay, so the roadmap is to look at the problem statement, research questions. I have a couple in there that I'll talk about because they're interrelated. The research plan, the deliverables, and then the so what. I also add a now what, and I'll explain what that means, but that will come after the so what and then the acknowledgements. So the problem statement is that despite the increasing number of children diagnosed with autism spectrum disorder in Arizona, there are no studies available exploring service access disparities by race or ethnicity among children with ASD in Arizona. And so it's really interesting that this is even a problem here because Arizona is one of the surveillance sites for the CDC's review of cases of who actually has autism, whether it's listed in medical and educational records or not listed, but medical and educational records are consistent with ASD criteria. So we have not necessarily the most accurate, but probably one of the most accurate numbers for children diagnosed in Arizona, but we have no one, at least to this point, has looked at, who's getting approved for services, what are the expenditures looking like, whose claims are processed by these different socio-demographics. So my research question relating to that is to look at whether there are existing disparities by race and ethnicity in access, otherwise, or Arizona healthcare cost containment system, otherwise known as access, expenditures among children with autism within Maricopa County. I can actually broaden it. I included my original question here, but I'm actually going to look at Arizona as a whole, since I was able to get that specific data for Arizona as a whole instead of just Maricopa County. And then which racial ethnic groups receive less or more Medicaid expenditures. So those are the two primary research questions. And this is rooted in a lot of autism data indicates, and this is national data, indicates that children from racial or ethnic minority backgrounds have poor quality of care that they receive. They're more likely to receive a diagnosis significantly later than their white counterparts. And a lot of it is income driven. So there is that caveat. However, it's pretty consistent across all states that ethnic minority children receive less support and services. And for a lot of the reasons that Dawn was mentioning, that, there's this assumption that these people don't want to go to the services. There's too much stigma, there's too much this, and there's all of these deficit model remarks made about these families. However, when you really look at micro level data, you see that families obviously are doing anything and everything they can for their kids, and they get a lot of system pushback that, you didn't show up, or you didn't call in time, or you didn't do this. And so they're getting lost in the system and not receiving the services that they have rights to within systems such as access. So that's where my research questions are driven from. How I'm going to look at that is to utilize access data that I was able to access from the Center for Health Information and Research, otherwise known as CHEER. What? No.
But the iPad's dead and now I can't watch my slime video.
I'm so sorry about that, but you're gonna have to figure that out with your dad. And so I was able to receive this data after a lot of, and I think many of you have already heard this story, but I want to reiterate it because it's important to note that, accessing data is critical for identifying whether there is a concern and how we can address it. And it was a challenge to get this data from the Center for Health Information and Research, given that I didn't have any money to pay them for it. And it should cost anywhere between $3,000 and $10,000 to get that data set put together. And the buildup of requests that they have within that center. However, I was able to get it. So what I have is access claims data for 2018 and initial year of enrollment in access for consumers age 18 and under, only for those who have autism listed as their primary diagnosis. So this doesn't include all access consumers. The total data set includes 42,782 kids. It also includes their race and ethnicity, year of first ASD diagnosis, the county that they reside in, and the median household income of the family. As well as, obviously I didn't put it in there, but the Medicaid claims totals for that year. To give you an idea of who's in this data set, there's a lot of other and non-specified race and ethnicities. I'm probably not going to include them because it's very murky. But I will prioritize including those who identified as Latino or Latina, Black or white, which comprises 34,140 participants in this data set. So I ran a couple of just really quick descriptive analyses to get an idea of what's happening in the data. I haven't ran anything in terms of mixed models, which I will need to. But just to show what this looks like is the median income. This is median income by race and ethnicity. And you can see that, and it says HS because within the data set, they're listed as Hispanic, but I label them as Latino, Latina, or Hispanic. So they have the lowest median income within the entire data set, whereas you can see that what's listed as Caucasian white in the data set has the highest mean of the median income. And then when you look at the total Medicaid claims that were approved for that year, you see the reverse relationship, right? So, I mean, the reverse, pretty much a complete turnaround, where the Latino kids, yes, they are getting a lot more claims totals approved compared to, and this is statistically significant without including any covariates, compared to the white children and compared to Black children. However, it's not very clear why that is. I want to highlight that you can have access and private insurance at the same time, so that the kids who have access through, how do I say this, through their income qualifications, who maybe were diagnosed with autism later, they didn't get access because they were diagnosed with autism and now had an eligibility status regardless of income for access. So it might be that the Latino kids, yes, they're getting more money. However, it's because they actually don't have access to other forms of private insurance that those children within the white and potentially within the Black group have access to. I keep saying access, it's redundant, but have meet qualifications through or have private pay through their home, through their parents. And just to be clear, what is covered through having access is behavioral health services. So these are kids who would otherwise now can have the applied behavioral analysis that's covered through access, be able to service them, and other forms of medical care. But really what we're talking about mostly for kids who are on the spectrum is behavioral health services. Another idea is to, now that I do have the data for the entire state, is to look at these claims totals by race, ethnicity, median income, and by county, given that there's a different, it's similar systems, but of course, as we all know, different systems operate in their own way. Whereas within Maricopa County is covered by Mercy Care. And then these counties over here are covered by Arizona Complete Health Complete Care Plan. And then within the northern area, we have Health Choice Arizona. So that there is the potential that the claims will differ by race and ethnicity within each different county. just given the dynamics and demographics within the different counties. However, I haven't looked at that at all yet. The deliverables and the timeline. The goal is to have a white paper completed by end of August 2020, and that will be provided to Access. So, but not just Access, but the Autism Spectrum Disorder Advisory Committee. This was developed, interestingly, it was developed sort of do the reverse of what I'm doing. The goal was for those children who had access or have access based on income criteria, that this committee was going to devote time and energy and resources to get them better situated with the opportunity to receive an autism diagnosis. So it would mitigate that late diagnosis and late service access point, but they didn't necessarily focus on what happens after. So I'm more looking at the what happens after, who was or for whom were the claims approved and at what basically degree. And they haven't met since July 2019. So it's also would be interesting to possibly reinvigorate, a focus on a different area of children with autism within Arizona. Another idea is to provide it to the Office of the Arizona Governor Policy Advisor for Health and Human Services. That is who the original advisory committee would report to. So it might be an opportunity to also just engage them simultaneously. And then of course, the Department of Developmental Disabilities agencies, which includes the Department of Economic Security. I didn't think about this deliverable until I chatted with Patricia a couple weeks ago, or Dr. Solis, to actually somehow promote this information on social media. I'm not Twitter savvy, so I'm not going to get into those details, but it is an idea. And then Datos is a report that's developed by the Hispanic Chamber of Commerce every year to focus on particular health issues within Arizona. And they've opened up the opportunity to also embed some sort of snippet or full report on this within there. And then an abstract will be submitted to the International Society for Autism Research annual conference, otherwise known as INSAR. That's the largest autism conference in the, pretty much in the entire world. Canceled this year, which is terrible, but hopefully we'll be up and running and be able to submit an abstract. Or even if, actually I shouldn't say it was canceled completely, they are doing electronic posters to be distributed this year. And then a manuscript around November 2020 to focus on, or to be submitted to either an autism journal, a social work journal, or a public health journal. The so what? Some of this is dry, right? It contributes to research knowledge base and informs policy, but it's also an opportunity to bridge the gaps across various academic and community sectors. Just as one very clear example, just even getting the data, like I said, this is something that should be public use data is actually something that's very private and guarded heavily by ASU Center, which has its own good aspects because of HIPAA concerns. However, there's a way, just like with what I've done, is to pull that data without identifying too much, but that we're allowing it to inform, what we're doing in terms of policies. And it identifies a gap area needed to address in order to enhance the health resilience of children and the economic resilience of families living in Arizona. As we know, especially as we know in these current times, if we have healthy kids who are receiving the services that they need, then we have parents that are able to, engage in more of their employment or just have healthier mindsets as well, because they know that their children are getting taken care of. The now what? And I add now what because I have my PhD advisor in social work when I was back in Michigan. His thing always was, okay, we already talked about it, so what? It's, we already know what that means, but what are you going to do about it? So what's the now what? So now what will be, it's going to be a platform for discussing solutions to the problem with key stakeholders by distributing the information to different people within the community. That will allow for more, better collaborative conversations, just like what we're having with Kerr. Like, I've learned so much from those of you who aren't so much in the academic setting, but within the community and connected to so many different resources and systems. And so that will allow, this project will allow for that as well. And it's an opportunity to engage the community in developing action items. If possible, presenting this to one of the autism parent groups, although that's still very much not diverse, I want to say. But it could be distributed to multiple different smaller support groups to hear, what are their thoughts and what have been their experiences trying to access different services through utilizing access. A potential solution is what Dawn was just talking about, the inclusion of community level programs to support Latinx or Latino, Latina, Hispanic children in accessing greater care and services through access approvals. One example is utilizing this intervention program that I have been working on for, like 10 years and implemented in California and here. And I have colleagues who've implemented different iterations of it in many different states, where we utilize community health workers, or in Spanish, this is called promotoras de salud. We train other Latina mothers who have children with autism at least 8 years or older, so that they've been through the system enough to know, sort of the caveats of how do you really get the service? Who do you need to talk to and how do you talk to them? With a guided curriculum, the program's called Parents Taking Action, and they deliver that information in 14 sessions, 2 hours each, to other Latina mothers who have children newly diagnosed with autism. And we found that to be really effective at helping to bridge the gap between the system considering mom, usually, either too aggressive, too demanding, or too, I don't care, I just don't want to deal with it. And helping the mom recognize that she has the strength and the power to do what she needs to do for her kid. And she's already been doing it, but she may have had resistance from the system. And so we help the promotoras that we train help those moms to better understand the system and to navigate it, and to have tools to work with their kids at home on their social communication. And, one thing I did want to mention, using that model, some would argue that it's inequitable because you do pay the community health workers less than you would pay a professional. And they do put in a lot of emotional labor in addition to, giving the information. But what's been fantastic is that there's more organizations and more pushes to professionalize it, like Dawn was mentioning, so that it does elevate it to a higher status than saying it's a community health worker or someone in the community. Well, now this person has that label as a promotora. So it actually also helps to build community capacity. The acknowledgements, definitely need to thank the children and families in the data set that do the work of, getting to all these different appointments, a lot of times arguing with doctors and demanding things that they need to demand and are their rights. And also just they put themselves on the line to be in this data set. So I really want to thank them. The Kerr Fellowship Program, Dr. Solis for her guidance, Susanna for everything that you do, and then all the other fellows who've really given me insight into different angles around their projects, resilience as a whole, and my project specifically. Dr. Hung Sung Oh, he is a fellow from last year's cohort who's in my department, and he really, he busted in my office one day and was like, you gotta apply for this. This is like exactly what you do. You have to apply. And I would have not otherwise recognized what this was had it not been for him. Dr. Ramona Denby Brinson, who's the dean at Ohio State University, she is the person who really pushed for me to be able to get this data before she left Arizona when she was our dean of research in our college. And then lastly, the Center for Health Information and Research for gathering the data and providing it at no cost. Thank you.
Awesome. Kristina, you know how close this hits to home. I am actually a mom of an autistic, almost 8-year-old. So I'm really interested in becoming a promotora. So we'll have to talk about that offline. Anyway, I'm going to open it up for questions. It looks like we're going to cut into our break time. So I hope you guys are okay with that. I will set the timer for a few minutes. Any questions? I think there's some in the chat. Let's see.
Prefers not to answer. There is research on who prefers not to answer. I'm not familiar with it in terms of this type of data though, because since it is, you know, this is not a survey questionnaire. This is who is specifically it within the data because they applied for access. So I don't know how that operates in that scenario.
Yeah, I was just wondering because there was a lot of people who preferred not to answer.
Well, it's not all unspecified. I just labeled it, I clumped it all together. There's a lot of Native American, so different tribes. There's also Asian, Filipino, but it's so everywhere that I just said, you know, for now, I'm not going to deal with it. What is it?
I think there's still a stigma, to be honest with you, on seeking services and, you know, banging on doors. And it breaks my heart because I see other parents go through it, and, you know, I can see signs of things, and I try to guide parents, like, you know, maybe you should ask about this or that without insulting, obviously. So yeah, there's definitely still a stigma.
Oh, I wanted to also show you all, this is just one example of what parents have to go through to try to figure out, how do I apply? What do I do? What am I eligible for? And this is the condensed version created by AZA United, which is Arizona Autism United, who are very supportive of families, but this is the condensed version of the how-to. And I do this work, and it doesn't help me either. And then another one I was going to show you is, let's see, just real quick, I think it's important to highlight what parents are having to go through to get this.
Yeah, I think you also have a language barrier.
Mm-hmm. So here's for those individuals that they have access, but access says, no, you can't have this for whatever reason, or they start taking things away. So now you just have to go through 7 easy steps, and then ta-da. And so that's why, you know, really with the promotora model, and that's the hope, is that this research that I'm doing, not just with this data set, but other angles, shows that we really need these community health workers to help, you know, mitigate and support and empower parents to feel like they can do what they're already probably trying to do, but they need more information to be more efficient at it. But more information that makes sense, not more information like this, because this is just a lot of too much for a lot of people.
Hey, Kristina, this is Dawn. Excellent presentation. I love your presence and just well-paced, and just the data so well, you know, presented. One of the pieces I wanted to share too is the ASU has a promotora network.
Mm-hmm.
Okay, you're aware of that. With
Yeah.
Bertha Carbajal.
Mm-hmm. Yeah,
That's exciting too. To really, I feel like it's just an underutilized workforce waiting to be activated and really waiting to be utilized in so many places in our health system. And you're right. I think a lot of we try to map out easy ways. Oh, here's just the user guide, 7 easy steps, or here's an app, just use the app. But really, people need a relationship, a navigator, a person by their side to say, hey, you can do it. It's all those little pieces woven in.
Exactly. And this program, as an example, and you know, it's interesting when people say peer coach, I do want to highlight that a promotora de salud model is not the same as a peer coach.
Right.
And the reason that it's different, and I know it sounds very similar, but it's really important not to forget that cultural aspect to it, because specifically within a promotora de salud model, you know, you're looking for somebody from the community, somebody who's facing the same issues. So there's some people that you call them promotoras because they're from the community and you train them in delivering diabetes information to other people, but they themselves have never had diabetes. It doesn't make them no longer an expert and useful, but it's critical to hold that model in order to really truly embody what a promotora de salud model is.
Thank you for that differentiation.
Yeah, and within the curriculum that I have, each session is actually also driven by culture because it was rooted from the culture. So for example, advocacy, that session, advocacy in the schools, talks about, you know, there's a vignette or a novella that's very dramatic of a mom walking in the school and is like, hi, can I have, you know, the form for my daughter? And they're like, wait, we need to get a translator. She's like, they just blow her off. And then the promotora and the mom would have a conversation around that. Like, has there ever been a time when you felt this way? And then you try to speak up, or, you know, it helps to have that dialogue and build the relationship. Is a promotora similar to an advocate? Not really, because they're more designed to deliver the information, not necessarily to go with a parent to, let's say, an IEP or individualized educational plan meeting to advocate for the kid and the mom, but they would give her that information about how to navigate that experience on her own. And we also really do. Oh, sorry. Can I finish this last thought?
Yes. Yes.
Okay, sorry. We also stress in the training that promotoras are not therapists, so that they don't further embed a larger emotional toll on themselves and feel like they can't support in that way, so that they recognize, you know, there are boundaries and it's important for their own safety, health, and you know, emotional weight to not go down that path. So that's another way that they are different than a therapist.